Hello everyone, welcome back to microlearning program of MFM. Today I would like to talk about the topic SGLT2 inhibitor. As we've already known that SGLT2 inhibitor is a very useful and effective drug for treating type 2 DM, and it is also useful for heart failure and some other renal diseases. These are for SGLT2 inhibitors: canagliflozin, dapagliflozin, empagliflozin, and artigliflozin. Okay, let's talk about mechanisms of action of SGLT2 inhibitors. Before talking about this, let's talk about what is SGLT2. SGLT2 is protein found in epithelial cells of the proximal renal tubule, and its function is glucose reabsorption and sodium reabsorption. It reabsorbs more than 90% of glucose and 65% of sodium. When we use SGLT2 inhibitor, it inhibits and blocks these actions of SGLT2, and it causes more than 90% of glucose excretions and 65% of sodium excretions. By this way, SGLT2 inhibitors reduce glucose and sodium level from the blood of the body. There are many trials done about SGLT2 inhibitor. These are trials about SGLT2 inhibitor: EMPERAC, CANVAS, CREDENCE, Tele-Edu 58, Vartis CV, and so on. Or these are trials. Trials are based on populations of diabetes mellitus, cardiovascular diseases, heart failure, and kidney diseases. And trials have shown SGLT2 inhibitors' effect on prevention of major adverse cardiovascular events, prevention of death, deterioration of kidney function, hospitalization for heart failure. There are some trials that show negative about SGLT2 inhibitor. The said SGLT2 inhibitor do not reduce cardiovascular adverse events. Vartis CV showed there is no significant effect of SGLT2 inhibitors on cardiovascular death. And Emperor Preserve says that SGLT2 inhibitor do not show a benefit with respect to kidney function. However, there are still so many benefits about SGLT2 inhibitors, so these are negligible. According to 2022 American Diabetes Association recommendation, patients with type 2 DMN, established atherosclerotic cardiovascular disease, and multiple risk factors or diabetic kidney disease, they can be treated with SGLT2 inhibitor, can reduce the risk of major adverse cardiovascular events. 2021 guidelines of the European Society of Cardiology and the 2022 guidelines of the American Heart Association also claims that treatment with SGLT2 inhibitor can reduce risks of major adverse cardiovascular events. However, every drug has both benefits and side effects. Here are some adverse events of SGLT2 inhibitor. SGLT2 inhibitor causes so much glucose excretion from urinary tract, so it causes favorable place for infections. So myocardial infections are common when treating with SGLT2 inhibitor. However, upper urinary tract infections and pyelonephritis are less common. Diabetic ketoacidosis can occur, particularly in elderly patients with volume depletion. But here, we need to know that diabetic ketoacidosis is not just like normal diabetic ketoacidosis, because here in case with SGLT2 inhibitor, there will be low pH and increase in ketone bodies, but glucose level may be within normal range. So this diabetic ketoacidosis will be euglycemic diabetic ketoacidosis. And another side effects we need to note is that canagliflozins in canvas programs have shown that it can double the incidence of lower limb amputations and an increase in bone fractures. So, in some patients with food ulcers are contraindicated to be given SGLT2 inhibitor. Here are doses of SGLT2 inhibitor. Empagliflozin in heart failure, its dose is 10 mg OD. If eGFR is 20 or greater than 20, there is no need to adjust dose of empagliflozin. In treating diabetes mellitus, dose of empagliflozin is 10 to 25 mg OD. If eGFR is 30 or greater than 30, no dose adjustments is required. Canagliflozin is not used for heart failure. In treating diabetes mellitus, dose of canagliflozin is 100 to 300 mg OD. If eGFR is 60 or greater than 60, there is no need to adjust canagliflozin dose. When eGFR is between 30 to 60, it's recommended to give 10 mg of canagliflozin OD. If eGFR is less than 30 and the treatment of canagliflozin is not initiated yet, it's better not to give canagliflozin. If eGFR less than 30 and albuminuria greater than 300 mg per day, dose of canagliflozin 100 mg OD is recommended to be given. Dose of dapagliflozin for heart failure is 10 mg OD. For diabetes mellitus, 5 to 10 mg OD. For CKD, its dose is 10 mg OD. If eGFR is 45 or still greater than 45, no dose adjustments is required for dapagliflozin. If eGFR becomes between 25 to 44, it's not recommended to treat diabetes mellitus with dapagliflozin. However, for heart failures and CKD, no dose adjustments is required. If eGFR becomes less than 25, initiations of dapagliflozin is not recommended. But if patient is on treatment and with heart failure or CKD, may continue 10 mg per day to reduce risks of eGFR decline, ESKD, CV death, and heart failure hospitalization. For dose of atroglyphosine diabetes mellitus, its dose is 5 to 15 mg OD. If eGFR is still 45 or greater than 45, there is no need to adjust dose of atroglyphosine. If eGFR becomes less than 45, it's not recommended to use. Absolute contraindications for all SGLT2 inhibitors are patients who are treated with hemodialysis and patients who has hypersensitivity reaction to all four SGLT2 inhibitors. These are absolute contraindications for SGLT2 inhibitors. This is references. That's all. Thank you so much for your attention.